Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1. Questions 31 to 36. You will hear an interview with a midwife called Christina Morello, who's talking about the time she spent working as a volunteer in South Sudan. You now have 90 seconds to read questions 31 to 36.
Today we're talking to Christina Morello, who's recently returned from South Sudan, where she was working as a volunteer midwife in a field hospital. Christina, could you tell us why you wanted to go and how you felt?
Well, I first arrived at the decision because I was dead set on making a difference to people who had nobody to turn to in desperate times. And, to be honest, from a selfish point of view, I naively thought it would be an adventure. I was just worried that the charities wouldn't need midwives. You always hear about the huge demand for nurses, and my experience lies in delivering babies. My parents, on the other hand, were terrified. They understood the risks better than me and realised that I could be working in very dangerous settings and that I hadn't properly prepared myself. They also warned me about homesickness and being away from my family for so long, something I hadn't really considered until they brought it up.
So, was your role in Sudan very different to the one you'd been doing in the UK before you left?
Very much so. The role entailed a huge variety of tasks, and they were all demanding in different ways. I helped set up maternity departments and trained local midwives in rural health centres. That was incredibly rewarding.
Yeah.
Watching my knowledge and expertise being passed on to other midwives and seeing them help the women in very remote areas who would otherwise have no access to maternity services felt so satisfying, like I was really making a difference. But what really shocked me was the sheer volume of deliveries I was dealing with. It was astonishing. There seemed to be a never-ending stream, and a lot of them were complicated. I regularly worked 36-hour shifts.
You mentioned that a lot of the deliveries were difficult. Could you expand on that for us?
Yes. Deliveries that I used to see as complicated back home became almost routine for me. I saw breech deliveries, twins, ectopic pregnancies, eclampsia, pre-eclampsia, and face presentations on a daily basis. And not only that, but all of these extremely dangerous situations have to be dealt with using very little medication. And you're sharing your kit with a team of people who are also working under extreme pressure. There's a desperate lack of funding for clinical equipment, which is why our work is so important. People don't use contraception, and they have huge families. The more children a mother has, the more complicated the delivery. In South Sudan, up to 13 children isn't uncommon, and that often leads to difficult and dangerous births.
Could you tell us about a patient who made a particular impression on you?
I remember when one patient, let's call her Margaret, came to the hospital in labour with twins. When we examined her, it became apparent that she needed an urgent caesarean section. This was impossible, as there was already one being performed, and we simply didn't have the staff or equipment to handle two simultaneously or to do a turnaround in time.
Right.
We had to work quickly together, overcome any language barriers, and really cooperate with each other to make sure that the necessary equipment was sterilised and available as soon as possible. I think Margaret's case really demonstrates how teamwork is everything out there. Eventually, the babies were both born naturally, safe and well. That was one of the happy endings.
It must have been quite a culture shock for you. What was most difficult for you to get used to?
I was in what's called a medium risk placement, which meant that fairly strict rules applied, and that took some getting used to. We weren't allowed to leave the hospital complex after nightfall, which was strange, but not too much of a problem, as I was usually only fit to have dinner and fall into bed anyway. The worst thing was constantly feeling dirty and uncomfortable. There was no break from the heat and humidity, and we only had bucket showers and a limited water supply. The bugs didn't help matters. They really added to the discomfort, and everybody always had something or other to complain or worry about. A sting, a bite, an itch or a rash.
So what qualities would you say are the most valuable for anyone who is thinking of volunteering?
Obviously, you can't apply unless you have all the qualifications, experience and skills that they're asking for. That's a given.
Right.
Language skills are a huge bonus. If you've even the most basic grasp of the local language, it'll get you out of all sorts of tricky situations. But what you really need is the ability to cope with the unexpected and be up for anything. When you're working in such extreme conditions, your team's the only thing that keeps you going. So if you put up obstacles, you'll cause more problems than you solve.
Now look at Extract 2. Extract 2, questions 37 to 42. You hear a GP, called Dr. Edward Symes, giving a presentation about how the condition called myalgic encephalomyelitis, ME, affects young people. You now have 90 seconds to read questions 37 to 42.
My name's Dr. Edward Symes, and I've come to talk to you today about a complex illness called myalgic encephalomyelitis, usually referred to as ME, and its effect on teenagers and adolescents. ME is a chronic neurological condition that affects many body systems, causing a variety of different symptoms, almost always including pain, feeling generally unwell, and sleep disturbance. I'd been working as a GP for about 20 years when my own daughter was 14 or 15, and one of her friends, let's call her Emma, was diagnosed with ME. She'd taken weeks off school, and none of her friends really knew what the problem was, other than that she was tired and not very well. The problem had started with a nasty bout of flu that she never fully recovered from. As time went on, Emma's friends seemed to abandon her one by one, as it became clear that even the shortest or most moderate forms of mental or physical exertion worsened her malaise and exhaustion. She ended up being excluded from almost every social activity, as she just couldn't cope with any exertion. The impact of this on her physical and mental health troubled me, as there seemed to be very little understanding and tolerance for her condition, and she was falling behind academically as well as socially. It was a chance meeting that resulted in me deciding to specialize in ME. One day, I bumped into Emma's mom at the local pharmacy, and we ended up talking for almost an hour. She was clearly desperate for someone to talk to. It was having a huge effect on the family. She'd had to give up her job in order to take care of Emma, as her anxiety was made much worse by being at work when her daughter was sick and alone at home. It's well documented that ME is a physical disease, and there's no evidence whatsoever to suggest that it's psychological, but there's so much misinformation, and there's no therapy or cure. Emma's friends had apparently spoken about her skipping school or getting out of things that she didn't want to do. There seemed to be a general feeling that she should toughen up and get on with school life as they had to. As a result, poor Emma's confidence had hit rock bottom. She felt that people saw her as lazy or attention-seeking. That's when I decided to turn my attention to researching the illness. Somebody who's so ill shouldn't have to worry about proving it to everybody. Another extremely unhelpful aspect of the illness is that it's so difficult to diagnose. What we really need is a valid laboratory test we can use. At the moment, we just have to go through the patient's medical history, analyze their symptoms, and try to exclude other illnesses. Sadly, this often means that many young patients suffer the illness for years before they're diagnosed, which is a shame because an earlier diagnosis helps to reduce the impact through support and intervention. Another issue is that ME can be tricky to identify in younger patients as they don't always report symptoms accurately. The seriousness of the condition can be hard for them to judge, as they may think that feeling exhausted or ill is normal and have learned to pace themselves and simply take part in fewer activities than they would if they were well. A reliable blood test would avoid all of these problems and might mean that the illness finally gets the attention it deserves. Perhaps the most challenging thing about having ME is the fact that it's so erratic. You just don't know how you'll be feeling at any given point in the future, which makes planning difficult. This often results in sufferers missing school and key social events. Feeling left out at a time when you're trying to establish your identity can trigger confusion and depression. And let's not forget that they do all of this on top of having to cope with debilitating medical symptoms. That's why I really want to emphasize that teenage sufferers require a lot of support and understanding from their families. For example, help with managing their social lives and visitors, because it can be difficult to keep friendships going. Another important point is that they shouldn't be put under too much academic stress, made to help out a lot at home, or keep up with physical exercise. A lot of parents think they should soldier on, but that's often the worst thing they can do. Trying to battle through is likely to lead to a total crash and a prolonged recovery. Sadly, there is no intervention or therapy for ME, but that doesn't mean that as health professionals, we can't help our patients to manage the symptoms and improve their quality of life. We need to be willing to try several and work out what makes the symptoms worse, what makes them better, and help the patient achieve a balance in their life so they can improve their daily function at such an important time. Because the symptoms vary from patient to patient, there isn't one single method that can be used. Patients want and need a GP who at least validates the illness and acknowledges its effects. They also appreciate us providing ongoing support and regularly reviewing and monitoring progress. We should be giving appropriate documentation and information to the family and school so that our patients are more likely to be believed. The patients themselves need to be involved in the process and adapt to life with the illness by respecting their physical limits and allowing themselves adequate rest. Before I go, I want to briefly mention one controversial method of treatment that is sometimes prescribed, and that's cognitive behavioral therapy, or CBT. Whilst it's been helpful for some pediatric patients, the effects on teenagers are modest at best. Claims that it can cure the illness are not supported by any follow-up studies. The theory behind it is that the patient is so frightened of the illness that's usually brought on by exercise that it worsens their health. CBT can be used as a way of getting back into exercise. However, the illness cannot be worsened by attitudes, and this theory goes against current understanding of the disease. It has led to patients being blamed for their failure to recover, and even worse, it frequently leads to severe relapses, as it usually insists on some form of exercise. On a final, relatively positive note, I should say that the majority of severely affected adolescents make a full recovery, and most others improve sufficiently to lead near full lives.
That is the end of Part C. You now have 2 minutes to check your answers.